GKNM Hospital of Coimbatore had recently performed a transcatheter aortic valve replacement surgery on a 73-year-old lady through a 3 mm hole on the thigh. Here we have the surgeon to comment on the surgery.
Good afternoon, I am Dr. Rajpal, Chair and Head Department of Cardiology, GKNM Hospital and Interventional Cardiologist, GKNM Hospital. It's a pleasure speaking to you. I just thought that we would share a very interesting case of transfemoral aortic valve replacement, which is actually a procedure wherein the valve is replaced without surgery. The interest in this case is that this is the story of a 73-year-old lady who came to us with narrowing of the most important valve of the heart. So it is through this valve that the blood is supplied to the entire body, and this valve became extremely narrow and the patient had severe breathlessness, couldn't walk a few feet. So as per convention, she was taken for surgery, and on the surgical table they found that the valve which is seated in the aorta was very, very stiff and brittle. That is, that it was just the entire aorta was like a piece of like a biscuit, it would just break, and nowhere would they be able to take stitches. Usually what they do, they cut open the aorta, replace the valve, and then take some stitches and close it up. But in this situation, the aorta was calcific, sunnambu sattan solvanga. So it was extremely calcific, and the entire valve was, the aorta was brittle. So that is, you touch it, it will not take a stitch, it will only crack. So in this situation, they saw this and immediately closed the chest and then sent the patient back to the cardiologist. And therefore, what we did was, we gave the patient a day's rest, and the next day after morning, we replaced the valve through a 3 mm hole through the leg. And the entire valve was passed from the leg into and across the aorta, and the valve replacement was done in a remote fashion from a small hole in the thigh. And this is a unique valve in the sense that it goes and seats itself and expands and crushes and displaces the existing valve. So, and it makes space for itself and it sits inside. So this was very good for the patient, and then the patient took another day's rest and then was discharged after 36 to 48 hours. So the advantages of this procedures are numerous, in the sense that you don't have surgery, you don't have a surgical scar, patient is ambulated very early, the quality of the life after this procedure is greatly increased. And so this is something that we have been doing routinely. But the point of interest in this case is that this patient was considered such high risk for surgery that the chest which was open was closed and the patient was sent back, and then we were able to do this through a small hole in the leg. This is a very interesting procedure, and I think once awareness of these procedures increase, we give more options to patients, and patients are able to choose and decide what they would like to do. The patient during the procedure is not under anesthesia. Patient is under something called conscious sedation. That is, the patient is awake, but at the same time is sleeping and not feeling any pain. But the patient is not actually anesthetized. That is, the patient is breathing on his own. There is no tube put, the patient is not under anesthesia. This is very important because old people, when they go into anesthesia, sometimes it's very difficult to take them off the ventilator. So this is very important. So patient was was conscious, and at the same time well sedated and cooperative with us. The procedure took around an hour or so, and we did not use any general anesthesia. We used local anesthesia and intravenous drugs given by the anesthesiologist and with conscious sedation. There will be 2 doctors and the anesthesiologist, the nurse, around 4 or 5 people will be there. Of course, we also have other people, in the sense the anesthesiologist has his own assistant, and it's a good team of around 5 to 6 people who work in tandem. It's very important to work together. The procedure, the risk is that this patient has had an open chest and a closed chest. That itself is one sort of has had a sternotomy, which we, and during the sternotomy, patient was anesthetized. So giving anesthesia again after 1 or 2 days will be high risk. So we did this without anesthesia, number one. And the second thing is we have to be very careful that if we slip up somewhere, usually if we do a procedure and something goes wrong, the patient can undergo surgery, the chest can be opened, things can be corrected and stitches can be taken. But in this case, that option does not exist because the surgeons have already opened and closed the chest. So we have to be very careful, very precise, and make sure that nothing goes wrong because there's no backup. Suppose there is some error on our side or something goes wrong, we always rely on the surgeon to open up and make the necessary corrections and finish. But in this case, such an opportunity was not there for us. So we have to be very precise and do it perfectly, and there should be no bleeding. Nothing should go wrong because we have no surgical backup.
So what is your message to the audience? Like these risky surgeries can also be handled.
Yeah, GKNM hospital has the capacity to routinely handle high-risk patients, and this is something we have been doing over the past many years, and that's why GKNM hospital has become a tertiary medical care center wherein we get patients who are extremely sick, and we do our best, and many times we do very well, and sometimes of course we do lose the battle. It's not that we win always. And it's also important for patients to know that there are alternatives to what has been conventionally been shown. So once these options should be given to the patient. Patient should decide along with the team members, along with the cardiologist and the surgeon should sit together, and then we should take to a decision what is best for the patient, and patient should be informed and be given all options.